you can see that this patient starts off with crowded anterior teeth with a crossbite, finishes with a nice final position. We did do some veneers, so we set this case up for a pre-restorative case. And I'll show you something here. This is really valuable to know. So he goes and gets the veneer preps done, and you can see that these are our temp veneers. What's really important to recognize is that when the patient is getting the restorative done, you do not want for this patient to have a full aligner or a full Essex that's covering the entire buccal of the teeth. Okay, Pontic's eruption compensations, we don't have any, so it doesn't matter. So get rid of this entire section. And now we get into the fun stuff. So attachments. All right, so this patient comes into our office, and this is an old case. I treated this patient 5 years ago now. And I'm going to show you that the techniques we used in this situation are still relevant. We still do the same things. But I will also point out anywhere that I would change protocols or techniques to make things more efficient. He presents to our office, and his main concern is the aesthetics, like most people. He realizes that he has a crossbite on his anterior teeth, and that's obviously causing some wear and damage. Now, the thing that we recognize when you look at this case to begin with, right off the bat, is the fact that his lateral incisors, they have a Bolton discrepancy. Now, what is a Bolton discrepancy? That is where your top arch and your bottom arch do not fit properly like a lid fitting on a box. And that's exactly how I describe it to my patients. And so how can you tell that right off the bat? You could look at the ClinCheck and get the measurements, or you could bust out some dental calipers and measure the width of the teeth. But there's a really easy way that you can tell in most cases if a patient has a Bolton discrepancy. First, you look to see, is this patient a class 1 molar and canine? Now, he is actually slightly a class 3 on his molar, but his canine, again, maybe slightly class 3, but close to class 1. On his left side, he's class 1 molar, class 1 canine. So we're looking pretty good. So if he is a class 1 molar and a class 1 canine, then we know that a Bolton discrepancy will be present, that the top arch will be either too small or the lower arch will be too big if the tooth sizes are not what they should be. Now, you guys are smart. You probably already look at this and say, look at those itty bitty lateral incisors. So if you ever see a lateral incisor that is smaller or the same size as the lower incisors, then you know you have a Bolton discrepancy. Now, in this case, because these lateral incisors are even smaller, then we know that we're probably going to have to address this, not just with doing buildups on the teeth to make them the normal size, but we even have to consider still doing IPR on the lowers because of his class 3 positioning, right? If he was just biting like he's got that slight class 3 on the molar that we see, if he was biting in perfect class 1 on both sides, we'd be less worried about him finishing with an edge-to-edge bite. But the reason why we end up, in many cases, with the posterior open bite has to do with the way that the occlusion's hitting, right? If you derotate his teeth here, and we fix all the positions of the arches just in the separate arches, and he bites down, if we don't do any IPR, if we don't do an extraction on the lowers, on the lower incisors, or we don't leave spaces for buildups, you do none of those, you will have this patient biting edge to edge, and there will be a posterior open bite. It's just the reality. That will be the situation because there will be a Bolton discrepancy. Now, where this is really relevant and important is that we can start talking to this patient then at the consult right now about the need for building up the teeth. So this is pretty easy to show him. All I explained to him is, hey, when we look at your teeth should fit like a lid fitting on a box, but they don't. Instead, the lid and the box are almost the same size. And so think about when you take a Tupperware container and you try to put a lid on that's too small and you force it on and it pops on in the back, great, but then in the front, it pops off. And so that's exactly what's happening to your teeth right now. And so in order for us to fix this, we can do some smoothing between your lower teeth to make them slightly smaller. But ultimately, when we look at this, your upper teeth need to actually get a bit bigger on the lateral incisors. Now, ideally, how we do that is we would like to plan a little bit of space behind those lateral incisors so that we can do a buildup. Now, I'm actually just going to go ahead. I'm pulling up a different case entirely right now that I would then show as a tooth twin. So Matt, I want you to go ahead and take a look at this patient here. And this patient's biting edge to edge. So the Tupperware and the lid also don't fit together properly. Okay, here's the case. You can see how he's biting edge to edge and he's damaging and smashing all of his front teeth. So what we're going to do is we're going to intentionally leave some space behind his lateral incisor. And this is where we finish moving his teeth with the orthodontics. Now we line up his gum lines, so those are in the right spots, but now we can go ahead and we can actually build up this tooth either with filling material or with a veneer. That's going to fill in that gap, and at the same time, we'll build up the edge of these teeth so that everything will look nice and aesthetic. So this is where he's at once we finish the orthodontics, and this is where he'll be at once we build the teeth back up. Again, we can do this either adding to the tooth with dental composite, or we can do it with a veneer. Right? Just the basic explanation. So once we explain that, he's fully on board for building those teeth up because he's seen somebody else like him who improved their teeth from doing the restorative treatment. So once we finish this consult, and he's also fine leaving spaces behind his laterals for either restorative buildups or for veneers. Hey, here's the situation on the lower. We notice that you're missing your second molar. And here's where it shows up on your pan. So you see how the roots are all tapering towards the back of your mouth? This is a little bit complicated because we can't go ahead and just close the space between these teeth by moving the biting part of your tooth. Instead, we've got to move the tooth and the root if we're going to make if we're going to be successful in moving this tooth forward. So there's two key things that we're going to hit with Matt right away. Number one is the fact that if we are moving this tooth forward into that position, we need you to be extraordinarily compliant. Because if you're not compliant and you don't wear these trays perfectly, we're not going to be successful with the Invisalign trays. It's just the reality. Number two is we're going to give ourselves an out right from the very beginning. We're going to talk to Matt about the fact that we might use other things to help out if the aligners aren't proving to be as successful as we hope. And in his case, we explained that to be brackets. Right? So we might go ahead and put a couple braces, some brackets and wires, on 3 or 4 teeth if needed in a very complicated position. So you're not going to have them everywhere, but you'll just get a little taste of what braces will be like if this tooth doesn't move effectively by itself. So that's all that Matthew really needs to hear in terms of our discussion. He doesn't want full braces across his front teeth. He wants to close that gap. Now you could go ahead and leave this space because right now the tooth is in some occlusion and the space is large enough that it is hygienic between that tooth and the one in front. There is definitely a time and place for leaving spaces between wisdom teeth that have drifted and the first molars. But in this situation, it's so tantalizingly close that we do choose to close the space. Okay, let's take a look at the ClinCheck. So this is ClinCheck number 1 coming back. So what are we looking to accomplish here? Well, number 1, let's go ahead and just focus on the top to start with. And actually, maybe I should show you exactly how I do approach it. So how I approach every single case, no matter what, how easy or hard they are, is I'm going to go ahead and you would have seen this from previous deconstructeds, I'm always using my checklist to go through and see if anything needs alterations or modifications. So I will do that. I'll go through this because I think the value of seeing how I actually approach these cases every single time has so much value. So again, no matter how easy or hard the case is, I go through the exact same way. So the first thing I'm going to do is I'm going to review the technician's comments. So is there anything that technicians have told me that is going to change my treatment plan? So they've told us that they trimmed the distal of some teeth. They've told me that they have corrected the class 3 malocclusion with the bite jump simulation. That might be a little bit relevant. Trim teeth removed on this plan. There was precision cuts prescribed, and they had some optimized attachments for root control. Okay, so nothing of significant value there. Like the things that would stick out to me would be if they told me that they were starting attachments halfway through treatment. That's something I don't want. But all in all, I'm happy with the text comments. Okay, what comes next? Well, was the bite set properly? We look from the side view. Yep. Front view. Yep, everything's good. Okay, at the end of treatment, did they give me passive trays that don't move the teeth, that are just holding things? They do. Back in the day, it used to be more than 4, but nowadays we can only get 4 of those. So we got our 4 passive aligners. Now in his case, I did something that I think is stupid. I'll call myself out when back in the past, like Steven from the past was an idiot. Like I'll tell you guys. So here's what I did that was stupid. On the bottom, you see that there's this blue 3 trays, which are overcorrection trays. So here's why this is stupid. I've asked the technicians to give me virtual C-chain, which tightens up the contacts between the teeth. Now, I've intentionally left space, which we'll talk about in a moment, but I've intentionally left space around that lateral incisor and around the other lateral incisor. So I want an extra millimeter of tooth width. But then I'm using this virtual C-chain to tighten up my contacts. And what it's going to do is if he actually uses these, it's going to force these teeth tighter together, and I will lose the space that I'm trying to intentionally create for restorative, right? That's stupid. It's dumb. Either he wears them and it wrecks things, or he doesn't wear them, and then I've just wasted plastic. So I almost never plan overcorrection, right, with those virtual C-chain tightening up the contacts on the first batch of aligners. I mean, in reality, I don't use it a lot at all, but I do not ever, ever, ever use it on the first batch of aligners because we know that there's going to be more than one set. Okay, so next we're in now to our final bite position. So is this case finishing? First, I'm going to make sure that I'm selecting on the top here this bite, and I'm going to have the bite jump happening, any bite jump happening at the end of treatment. Okay, that just means that any elastic simulation, like this little jump back of class 3, will only happen at the end of treatment. Now, this does not mean, so this bite jump that it's showing right now is not showing anything that happens with the Invisalign trays. This is not the trays doing anything. This is giving a simulation of the elastics physically moving the position of the lower arch from, again, the usage of the elastics of those auxiliaries. Now, in reality, is the jaw going to be moved backwards? Well, I mean, theoretically, you could actually force it back if you use really, really heavy elastics. You could force the lower jaw back and you could put pressure on the retrodiscal tissue and cause TMD. So you don't use heavy, heavy elastics when doing class 3. In reality, the bite jump that they're showing here is not realistic to really happen if we're using kind of medium to light elastics. You're not going to cause TMD, but it will not actually happen as shown. This is, again, slightly a fantasy of what's being shown here. So the actual position will be the movements that happen before that jump occurs. Okay, but in terms of my final position here, without showing that bite jump, right, without them moving the arch back, am I happy with my bite position? Am I in a class 1 molar and canine, or in a position that I'm comfortable with for my overjet? And even though I'm tight with my overjet, I think we're pretty close. So yes, I'm happy with my final bite position being pretty close to class 1 molar canine. Now we'll talk about why we're using these elastics as well in just a moment, but the next thing I'm going to look at is the curvus B. So let's get rid of the photos. We don't really need those right now. When we compare at the beginning of treatment, is there a significant curvus B? Not really. The lower incisors do sit a little higher than the molars, but we don't have a significant curvus B. Okay, I'm not looking at the movements of anything. I'm just kind of looking at the beginning and at the end. And one tip actually for you guys is right now, I actually recommend that you do not put your attachments on when you're looking and evaluating and going through this checklist, because the attachments section comes up later. So don't look at the attachments. Okay, the next question is, do we need a lot of expansion? Are we in a crossbite? Do we have a narrow arch? Do we have poor upper arch development? But not really. I mean, the molars can benefit from some derotation and a bit of expansion, but we're not severely constricted. So I think our expansion situation is fine. I don't think we need to modify that too much, even though we are going to develop the arches slightly. And the upper 6s, the first molars, we want to derotate those teeth slightly, and they are. So I'm happy. Next, smile arc. What's going on with his smile? This one to me is really relevant, especially as we start looking at restorative. So his smile arc is okay. So he's not showing any gums. We would be fine to extrude any teeth. So if any teeth extrude in the anterior, that is a good thing. That is going to help his smile arc because then his teeth will follow his lower lip. So extrusion is not a bad thing at all. But we definitely do not want to intrude any anterior teeth. In terms of his midlines, because that's going to be coming up in just a sec. So I actually have changed the order of this nowadays. So I look at midlines at the same time as we look at the smile arc. If you look at his philtrum is right here. So his midline is maybe slightly to his right. He's got some asymmetries with his nose, a bit of a deviation to his right. But I would say his midline, unless you have a midline that's shifted more than 4 millimeters off from your facial midline, that's when it becomes noticeable to dentists and orthodontists. And lay people, it's even more than that. And so I do not have a problem right now with his midline whatsoever. So we're not really going to be making any changes there. So we don't need to make significant changes for his smile arc, and we don't need to make significant changes for his midline. If we do anything for smile arc, though, we would focus on extrusion. And he has no cans. Okay, the next one is, do we need to do IPR? And do we need to do IPR because of fragile tissues? So let's go back to his photos again and just look at the tissues. Does this look like good, healthy gingiva? Yes. Is it a good, thick biotype? Yeah, it is. So am I comfortable here knowing that if we do some expansion, that he'll be fine, that he's not at a high rate of recession risk? Totally. This is fine. This isn't going to be a problem at all. So I do not need to do IPR then for fragile tissues. Do I need to do IPR for Bolton? Now, this is a different consideration because we talked about it already. Is Bolton relevant? Yes, totally. If you are a class 1 or a class 3, Bolton is important. He is a class 3, which means that Bolton is even more important. If we click on our Bolton at the top of our window here and we evaluate, it's going to tell us that our Bolton is a 2.7 millimeters between his 3 to 3. So he does have a Bolton discrepancy. And his Bolton discrepancy is not small. It's 2.7 millimeters. Now, how are we going to be making up for that Bolton discrepancy? Now, part of this will be through buildups. That's why we've asked the technicians to leave us 1 millimeter of space around the lateral incisors. Now, we could have, and maybe should have, left the spaces slightly asymmetric, because if you look at the table here, it tells you that the 1, 2, so the lateral on his right side, for the Americans who are watching this right now, is 6.1, whereas on the left side, his upper left lateral is about 0.5 millimeter smaller than that. So if I was doing this again, I probably would focus on leaving more space around his upper left lateral and a little bit less space around his upper right lateral. Now, we didn't, but that's something that maybe I would change. But even if we do the 2 millimeters of Bolton correction, right? So if we have 2 millimeters of extra tooth structure on the lower relative to the upper, right? That doesn't mean that the issue, it says right there that it's telling us there's a 2.7 millimeter Bolton on the lower arch. That does not mean that the lower arch is too big. I really wish that Invisalign would look at the tooth widths and then it would recognize like, no, the Bolton is not because of the lower. The Bolton is because of the upper laterals. Like that makes sense. You just look at the upper laterals and you can tell that. There's no magic formula you need. But it shows up on the Bolton table always either as a mandibular excess or a maxillary excess. There's no situation where it will say that there is a maxillary deficiency. Just to repeat that again, it will not tell you that there is a maxillary deficiency or a mandibular deficiency when looking at the Bolton. So when you see it saying here that there's an excess in the mandible of 2.7 millimeters in the 3 to 3 region, and just ignore the 6 to 6 region right now, it's not as relevant. But this is just telling us then that we need to adjust that. So we either make the top arch bigger, make the bottom arch smaller, or do both. So if we have 2.7 millimeters that we'd like to correct just to get us back to baseline, we're adding 1 millimeter on one upper lateral, 1 millimeter on the upper lateral. That means that instead of 2.7, now we have a 0.7 excess on the upper arch, or on the lower arch. Now we go ahead and we plan in some IPR on the lower arch of 0.4. We got 0.4, 0.8, 1.2, 1.6, 2.0. So we're actually doing more correction on the lower. And the reason why we're doing more correction on the lower is because the patient is actually slightly class 3. Right? We're compensating. If we wanted to just compensate for the Bolton alone, we would have just done 0.7 millimeters. We would have done like 2 of these 0.4s. Right? That would have been 0.8 millimeters. That would have been the balance. But we're worried still about not having enough overjet. So that's why we did a little bit more IPR. Now, people ask me all the time, well, how much IPR are you comfortable doing, Stephen? And my answer to you is as much as is needed within reason. We are always so scared as general dentists of doing IPR, and it's not something we have to be scared of. It is not a really challenging or difficult procedure if you do it with a burr and you use the right burr. It can take you 2 minutes to do, and it's really easy and straightforward. I like doing 0.4 millimeters of IPR between the lower incisors because that allows me, if I need to, if I absolutely need to, I can do another 0.4 between those contacts for a total of 0.8 millimeters between contacts, which means that I would have reduced 0.4 off of one tooth and 0.4 off of the other tooth, right, in this contact. Now, is this something I'm saying you have to do or that everybody should do? No, I save that for kind of the worst case scenarios and the most extreme cases. In a lot of cases, I don't do any IPR. But studies show that you can do up to 1.5 millimeters between each contact and still be safe in terms of sensitivity and decay. And working with Tarek Albiali, an orthodontist out of Edmonton who teaches at the University of Alberta, I've seen many cases where he does more than 1 millimeter of IPR between a contact with excellent results. So again, I'm not saying that we need to be doing tremendous amounts of IPR, but that's why I like the 0.4s, is that I like being able to do 0.4, and if I have to do IPR again, I can do another 0.4 between contacts, but I'm not using that as my baseline. That is something that I'm reserving if we run into significant challenges. But with this alone, with this plan setup, this is now addressing my Bolton discrepancy. All right, so Bolton in this situation is fixed. If there was no IPR on the lower, or I needed spaces on the upper, then I would go in and I would make modifications. And I'll show you how to make modifications on just our final plan, because unfortunately it won't let me make modifications on an old plan. So all I can do is just review what we did. And then in the future, I can go ahead, or not in the future, sorry, but on the current ClinCheck, which is fine, it's finished, but I'll show you how you can go ahead and like add some IPR on the lower and open spaces. Okay, this section here I actually don't include in all my lectures, but reducing refinements. So I'll often look at the root tip on the pan and look for root parallelism. That's a tongue twister. Let's go to our actual photos here. So what roots struggle with parallelism? I mean, nothing really in the anterior or the premolars. It's just going to be this guy on the bottom, our second molar. So we want to make sure at the end of the day that we have root parallelism on our lower molar. Next, we're going to look at the occlusion. So we want to have, if there's a deep bite, we normally want to have no contacts on our anterior and heavy contacts on our posterior. If you have an open bite, anterior open bite, we want to have no contacts on our posterior and only contacts on our anterior. Well, what about when we have the normal amount of overbite? Then in this case here, I'm just looking for occlusion that's balanced. So I'm fine with occlusion that is balanced between my premolars, my molars, and my canines. Next one is evaluate the incisal edge to see if there's enough overjet. we're tight. We're definitely tight, but I think we do have enough space. Okay, do we need torque on our incisors? And if we do need torque on our incisors, so torque being the buccolingual orientation, often I'll put in a little bit of intrusion while that occurs. Again, this is pretty advanced stuff. Like, don't worry right now if you don't understand all of these. This is actually like a protocol. I kind of pulled up like my top level protocol that I don't always use or show when I'm teaching, just because these are some very specific things. But essentially, I'm fine with the final position of these teeth. We could have a little bit more palatal root torque, but it's not going to affect anything here. If expanding, we need 10 degrees of buccal root torque. We're not expanding. If extracting, add a virtual gable bend. We're not. If class 1, borderline class 3, consider adding class 3 hooks. Okay, why is that? Why are we looking? Now, when we click on our attachments, you'll see, why are we considering using hooks to run from our lower canine to our upper first molar if we're doing IPR in the anterior? And the answer to this is that even though we are assuming that the IPR gets done and the anterior teeth are going to be retracting into the spaces created by the IPR, the canine will drift forward slightly into that space. The first premolar will slightly drift forward into the canine space. The second premolar slightly into that first premolar space, right? It's a very minuscule amount, but when you're doing enough IPR, especially if we're getting distal of the canines and distal of the first premolar, then even doing IPR between these teeth, the molars will drift forward a little bit into that space. And so utilizing class 3 elastics whenever you're doing anterior or premolar IPR will help pull back those anterior teeth into the IPR spaces. Again, did it really matter in this particular case? Because we just did the IPR between our incisors? In reality, no, it didn't. But does it help when you have spaces that you're doing IPR distal to the canines and in the premolars? Absolutely. So we probably didn't really need these class 3 elastic hooks, but we're just actually having the patient wear them at nighttime. And that's the reason I'm going from the slit to the slit, is because with the elastics being used just at nighttime, there's nothing to break off, like there's no buttons involved. And I'm just going to tell them, hey, wear these elastics at nighttime. They're going to help a little bit. If he doesn't, it's not the end of the world. So that's essentially why we have the button or the precision cuts. Okay, what's next on our list? By the way, we're up to 258 people, so one day we'll get to our 1,000. Can everybody just text 750 friends right now and tell them to jump on this call? Okay, next, staging. So is there any round tripping occurring? So our teeth moving one direction and then moving back in a different direction. So we create spaces for the laterals. Okay, derotation, alignment. There's nothing too crazy going on that I see. Like, for the most part, everything is moving from its initial position to its final position. That's all we're looking for when we have this round tripping one. It's just, there's no dumb movement happening. Okay, the next one was evaluate extrusion predictability. Sometimes extrusion doesn't occur as shown. So is anything extruding? Not really. Again, remember we said we could have extruded our centrals and laterals? We didn't in this case, but we could have. But there's no major extrusion predictability. But if there was extrusion occurring, then we want to make sure we have an attachment on any tooth extruding. Next one's going to be, are any black triangles opening up that are going to look really unaesthetic that we should consider doing IPR on in our first set so the patient doesn't end up with a giant black triangle? Now, the answer to that is somewhat yes, but he's planning to do veneers on his centrals as well. So I don't really care about the space between his centrals, like the black triangle opening, because that can be addressed later. So black triangles doesn't matter. Next one, is IPR occurring when the contacts are derotated? right? I don't like doing IPR between super crowded contacts because then you end up doing the IPR on the wrong area of the tooth. So right now, the IPR is being done when there's lots of crowding. So I would not recommend this. I would change the staging here. I think IPR could be done at aligner 26. That's fine. But at aligner number 1, this is a disaster to try and get in with a burr. You're going to do way more IPR on the buccal of one tooth than the lingual of the other. And using the seesaw strips, it's the same thing, but you're going to have to pretty much start a fire between his teeth in order to get this down to what you need it to be for the IPR. So I am not happy with this IPR because it should be occurring when contacts are open. So I'm just going to change this instruction to the technicians and say, do IPR at aligner 26. That's it. Or I'm going to say actually do all IPR. Okay, so now the IPR happens at the same time. Next thing would be attachments. Are there any attachments that are showing up mid-treatment? I can click on my staging feature to see this. So you can see that there's no red triangles appearing in the middle of treatment. So they're not putting any attachments on halfway through because that's super inefficient. And I hate it when they do that. Next, is the number of trays okay? Yeah, we're looking at 30-ish. Times that by 7 days. That means that we're looking at 30 weeks. So that's what, like 7 times 8 is 28. So we're looking at like 7 months. Or 7 times 4, sorry, is 28. So we're looking at about 7 months. I think that's fine for this initial movement, but what you're going to see is it's not actually enough for the molar movement. But we'll come to that in a minute. Okay, Pontic's eruption compensations. We don't have any, so it doesn't matter. So get rid of this entire section. And now we get into the fun stuff. So attachments. So retention attachments. Do we need attachments for deep bite correction? No, we don't actually. Usually we do. Almost everybody has a deep bite, but not this patient. Do we need attachments for expansion? Well, we're not really expanding, so not really, but you could pop on some attachments to his upper second molars. Next one is upper incisors. Do we have some bigger incisor movements happening? Well, yes. So we absolutely need attachments on the lateral incisors, which we have. Next one, root rotations and difficult movements. Do we have anything that has a difficult movement occurring? Wink, wink, nudge, nudge. Yes, we do. We have an attachment that needs to, or a movement that needs to happen on this wisdom tooth, bringing the tooth forward. Now, if you've taken the attachments biomechanics course, you've seen how we've looked to address a case like this, where we try to swing the roots mesially by essentially having 2 4-millimeter horizontal attachments and then really controlling the root position, the root tip. Now, I did not design a great ClinCheck here. I will be the first to admit it. This is gross. Why is it gross? Well, because we're trying to do too much too fast. Realistically, so I do have the right attachment set up here. A buccal and a lingual horizontal attachment pulled out to its full thickness, which this isn't quite to its full thickness. We could have pulled this out more. Allows the trays to grip underneath in this mesial area. Again, if you want to see how this is treated successfully using aligners, check out the attachments and biomechanics course and you'll see a full breakdown. But what I really would do differently now, if I was doing this, is I would not close this space entirely. I would instead work on the root movement only, and I would keep the same amount of space. So the root would move, but not the crown. And it might take me 3 batches or 4 batches of trays to be successful with this, but I would eventually accomplish that. But instead, I'm trying to upright the root. So the root's trying to swing mesially. Right? I don't have roots showing here because I didn't have a CBCT integration. But if you looked at this, you would see the roots moving mesially. This mesial cusp is extruding. And it's closing the space. And it's just flying through air. Like it's moving so fast. Again, the movements of everything else is fine in 30 aligners, but the movements of moving a root through that much bone is going to take time, especially when you consider the fact that there's even more dense bone to the mesial of this tooth. right? Check out the sclerotic bone from where that second molar came out. So there's dense bone. So how do we expect that we're going to move this root? I don't know how many millimeters this is. Like the width of a molar is 10 millimeters. So this is probably 6 millimeters that we need to move this. How do we expect to move that root that quickly and be successful? And the reality is we aren't going to be, we're not, because it's moving too quickly. So if I was treating this and I was wanting to be successful using aligners, I would expect that I probably should have like a year's worth of trays minimum. And I would do that just to even move the root most of the way. It wouldn't even fully get the root there. But I don't do that. I leave this as is, and you'll see how it's going to burn us. But in reality, I would tell this patient again at the beginning of treatment, closing that space and moving that root forward is going to take 1.5 to 2 years to move the root 7 millimeters through bone, because you need osteoclasts and osteoblasts to do the work here. Right? It doesn't matter what magic we try to use with Invisalign aligners or braces or anything else. Like, it is going to take time for this root to move. That is just the reality of moving teeth through bone. Whereas crowns can move really quickly. And you'll see how that happens in this plan. Is what's going to happen is this root is just going to dump forward. Or the crown is going to dump forward. Okay, so root rotations and difficult movements. I recognize the fact that I had those and I put good attachments on. I just did not slow down the number of aligners appropriately. Next, are there any attachments on crowns? There were not. And then the last section here, elastic cutouts. We're not going to go into this because I already talked about the class 3 cutouts. And then review your own comments and ensure nothing is missing. So we recognize that we did want to move that tooth. Could have done it differently, but the only thing I really need them to do then is to add IPR or adjust the IPR staging to be on tray 26. So that's about it for treatment plan number 1. Fortunately, I had a really good prescription form, so I got back most of what I needed. But let's just go ahead and jump to tray 9 or plan 19. Here's the spoiler. This is what the tooth looks like after we've closed the space and everything's moved. But let me just modify this so I can show you what things would look like on the uppers if I needed to go in there and create space around the lateral myself, because I'm not asking the technicians to do that. If I needed to create space, I'd click tooth, I'd come in here. Now what's cool is you can actually hold control now and select 2 teeth at the same time and then add spacing for 2 contacts at once. Or I could actually click and hold control and now select these other contacts too and add spacing for 4 contacts at once. So say I wanted 0.5 millimeter of space around there, I just added that 0.5 millimeter space everywhere. On the lower, say I need to add some more IPR here. Same thing, let's just say I was doing it between the premolars. I can go ahead and select multiple contacts now and do IPR between multiple contacts. Now again, this plan would look slightly different for those who are in Clearly Select, because doctors who are in Clearly Select get access to our specific Clearly Select engine. So a lot of these considerations of how we're going through step by step, they're automatically done for doctors that are in Clearly Select, because with our individualized personalized plan, it allows you to kind of cut through and it will automatically put a bunch of these things in place so you don't even need to think about it. But this is essentially then where we're at with our plan in terms of, again, how you can make those modifications and adjustments yourself. Pretty easy stuff. Again, that was just for demonstration purposes. So again, from our initial plan, we're right here. I did change out a few of the attachments. Oh, good point. I should point out this one right here. I want to make sure that this canine actually moves and rotates nicely. And this is a bit of a harder movement. There's some rotation that's happening here. And so I changed out the attachment from the optimized attachment to a vertical conventional attachment, because I want to ensure that if this doesn't track and move properly on my next batch, that I do not need to change that attachment. I don't want to change it because I want to ensure that we get rotation of that tooth, ideally with the first attachment, whether it's the optimized attachment or the conventional attachment. But I want to ensure that if it doesn't happen, that I don't need to waste my time putting new attachments on the teeth, right? I can just go ahead and leave that attachment in place and then finish any of the movements. Okay, and you can see this is what things look like. I don't review these cases before I go through them. And again, I did this 5 years ago. But you can see here how I did the exact same thing. I didn't put it at tray number 26, I put it at tray 24. I asked the technicians to derotate the contacts and we'll do IPR all at the exact same time. So that's what was done. Okay, so let's go ahead and take a look at how successful we are with the actual movements. So this is his initial. This is where we're at after our first batch of aligners. So we've done the IPR on the lower. The thing is, you can realize that he wasn't great about wearing his trays at the end of this batch. And actually, nope, sorry. That's when we did IPR, we took pictures that day. This is the photos of where he was at the end of that batch. You can see this is right after I did the IPR, and then this is where he's at once that IPR has closed. Oh, no, sorry, I'm wrong, because you can see buttons showing up on those teeth then. Nope, I'm wrong again, guys. What I changed in this last plan, let me go back, just so you see, because you're gonna wonder about this. I did change out, I would do this differently now, but I did change this out and I put buttons on. And I put the button cutout in tray plan number 2 on the lower canine to the lingual of the upper 6, running those class 3 elastics. I think what I actually originally had is what I would do nowadays. I would just use the slits. So that is the reason why, when we look at his plan, you can see that he does have these button cutouts or buttons on the lower, running those class 3 elastics. But this is less comfortable and it has more hardware that can fall off for him just wearing these in the daytime. Okay, so this is where he's at the end of the first batch. So we have some spaces that have opened up around his lateral incisors. That's great. Could use a little bit more space around his other lateral. He's got a slight overjet, but not a ton. And that's why we're actually going to end up doing a little bit more IPR in his case. And then when you look at his lower molar, is moving forward, it's closing the space, but it's dumping. That mesial cusp is getting lower and lower, right? This is not a good contact between the teeth. And that's something that we're going to have to address. So I'll show you the plan. Here's his next batch. So you can see that his bite's a little bit tight still. He's kind of hitting edge to edge on this lateral incisor. We're needing to open a bit more space, so we're going to do that. But we also do actually plan to do a slight increase in the amount of IPR done here. So we added 0.3 millimeters in on the lowers and 0.4 because we're trying to move his midline on the lower slightly over. And again, I'm okay doing IPR if need be of more than, or usually up to 0.8. But again, Dr. Tarek Albiali, who's an amazing orthodontist, he'll do IPR of up to 1.5 if he really, really had to in a significant class 3 case. So let's go ahead and take a look at my molar region. We've been going through a lot of basic stuff so far, but now let's get into the complicated. You're not here for the basic, you're here for the crazy. So what are we trying to do? We're trying to do nonsense is what we're trying to do, right? This is never going to happen. We're trying to upright that tooth in 36, 35 aligners and swing that root through the bone. Like it's just not going to happen. Because we weren't successful in the first batch, well, we have even worse grip of the plastic now. When we had space around that lower molar, the plastic could grip around the entire tooth. But now we can't. The plastic will not grip on the mesial surface. Again, I'll point out one little change I made. I wouldn't do this now again, but I actually put 2 attachments on the buckle. You don't need those 2 attachments. You can see one of them even broke off. The attachments that matter is having an attachment on the mesial of the lingual and the mesial of the buckle. That's what matters. So again, the attachment design was fine. It's the fact that it's trying to do too much too fast without having space between this tooth and the neighboring tooth. Okay, so that's the plan. In terms of the actual results of what we get, well, here's the plan. Let me show you. Here's the molar, or the first molar. So it's better. It's improved a little bit in terms of its height from there to here, but it's still dumped. It hasn't really improved a tremendous amount. This is still not a good contact. When we look at our pan, the root has not improved. You can see a widening of the PDL, but not by much. Like it's, sure, maybe the PDL is wider, but the root has not moved. And when you look at the pan, you can really see how open that contact still is. We're now at the point, though, where our overjet is actually better. We're no longer biting in a significantly tight overjet. And so the patient at this point is actually set up pretty nicely to move ahead with doing his restorative. One thing that I do a little bit maybe different than some, but I know a lot of doctors do it this way too. I don't wait on finishing the entire Invisalign case before we do the restorative. So in this situation here, we've got better overjet and we've got the teeth set up in the proper position. At this point, we're going to go ahead and plan to do the restorative because I'm then going to ensure that the best restorative possible is done. And if we need a little bit more overjet, then we can go ahead and work on the correction of the teeth after the restorative is completed. So I tell the restorative dentist, because I just do orthodontics, I don't do any Invisalign. Again, I am a GP, I'm not an orthodontist, but I just do Invisalign. That's all I do. I shouldn't say Invisalign, I just do orthodontics. So obviously we're using some braces coming up. So in this case here, at this point, even though we haven't finished addressing his lower molar issue, we're gonna go ahead and get the restorative work done. And I'll show you something here. This is really valuable to know. So he goes and gets the veneer preps done, and you can see that these are our temp veneers. What's really important to recognize is that when the patient is getting the restorative done, you do not want for this patient to have a full aligner or a full Essex that's covering the entire buccal of the teeth. Because if this plastic goes all the way up to these gum lines, it's going to pull off the temp crown or the temp veneer when he takes it on and off. So what you want to do is you just get a regular Essex made by a dental lab or make it in-house. We use the 3D printer, print our own, vacuum form it down, pretty quick and easy. But then you take a pair of crown and bridge scissors and you just cut down on the tooth in front of the ones that are prepped, cut all the way across. We could have gone a little bit lower, but what you also do not want to do not have this patient not wear retainers for the next 2 weeks while this temp or till the veneers are made. Like that is a disaster. That is the worst possible thing you could do. Like I'll even say to this camera too, like don't do it. Always make sure that you have a retainer or aligners or something on the teeth when you have temps on them. Because if these teeth shift and move, and then he comes to get them inserted and you try to glue them onto the teeth and they are not in the same spot, the contacts will have changed and you'll try to put them on and they won't fit. They physically will not be able to all get on. So you could cement maybe like the one lateral and the other central, but then you'll be like, well, the other two, the contact is hitting because they might have rotated a bit. And then what do? Because do you try and move these teeth with aligners back to where they were? But now you don't have attachments on the teeth and you have the enamel shaved down, especially if it was a crown. So now you need to try and move the teeth back to where they were, but you're going to have to remake the crowns or the veneers because you're not going to get them in the exact same spot. And so now who's paying for that? Is the lab eating that? Are you eating that? So when they get to this point right here, I am so unequivocally clear to this patient, I will murder you, not quite, but I will murder you, figuratively speaking, if you do not wear your retainers for the next 2 weeks. Like you could have been a mediocre patient during treatment. I'm fine with that. All is forgiven right now, except you must wear your retainers like a champ all the time until those veneers go in, else they will not fit and we will be stuck in no man's land. And I put the fear of God in them. So he now is like, okay, he's great with it. So all is good. He goes ahead, he gets his veneers inserted. So pretty straightforward. Now, at the same time, when he comes back now, this is where we're going to go ahead and add our auxiliaries. What we're going to do is we recognize the fact that, well, we want to work on the position of these teeth. And we're not having success with the aligners, so we're going to focus instead on using some partial brackets. Oh, let me go back here. All right, so here was him with his, I hope that was in, that you saw this before. So here's his partial tray. I don't know if that was showing on the screen or not before. Right, cut it where the canine is. Cut it a little bit lower than this even, would be slightly better, but that's fine. And then now we're gonna go ahead and we're gonna be bonding on our brackets. Okay, so normally you place brackets in the middle of the teeth. But in this case here, we're just putting them right on the gingival margin because we don't need them to be right in the middle of the tooth. Now we could do them in the middle of the tooth, but we're actually planning here to put them lower down so that we can use aligners over top. Because on our plan now, we've just asked for button cutouts, right? We've just got button cutouts on the 4s and the 5s and the 6 and the 8. Now it might be that the wire gets hit by the aligner. And so if the aligner is actually hitting the wire, we may need to take some crown and bridge scissors and cut right here below this attachment. And what you'll actually see is on his plan, notice how the attachment, I actually trim the attachment down because the bracket would hit the attachment. Right, let me zoom in on that, right here. So on the 6, the first molar, we trim this attachment down to be less high, slightly. And the bracket goes underneath that. So looking then at his ClinCheck right here, we're going to have to take some scissors and cut this area out as well. And we might need to cut wherever. We might need to trim as much as we need to. But the nice thing is we're trying to keep these teeth still covered by aligners because it'll help control the position of the teeth. Where we'll often go ahead and cut so we don't have it covered with aligners is we might cut off the back tooth. We'll cut off the 8. Because if we cut off the 8, then that can move as fast, as quickly as the brackets will allow it to move. So in this case, that is what we do too, is we cut around here as needed, and then we cut off the 8. The 6, 5, 4, and 3, we're not cutting off because we want these teeth to all stay locked into the aligner so that we don't get any unwanted side effect movements, but you'll see that still happens anyways. You're gonna see two things, but let me find my X-ray because it shows it better than anything else, is how I position the bracket on this tooth. So on these 3 teeth, we're just placing the brackets right on the gum line. There's nothing crazy going on with it. It's pretty straightforward and easy. But on the second molar, I guess the third molar, what we're gonna do is we cheat the bracket position. Normally when you place a bracket, you would place it so that it sits parallel to the occlusal surface, the occlusal aspect. All right, and that's kind of what would go on for these 3, but we did the same thing, but we just did a little bit more gingivally, right? So pretty much we're parallel here. What we do here is we actually cheat the bracket to be at an angle relative to the occlusal surface. The reason why is that we actually want the wire to bind in the slot here and here slightly and kick the root to the mesial. So we're cheating this more upright. Like we're not gonna go like vertical on it like this, but we're kind of going more like halfway between vertical and horizontal with our positioning. But what you're gonna notice, again, I show you the good, the bad, and the ugly, is 2 things will happen that are gonna make this a bit more complicated. Number 1 is we actually had our wire pop out. So the wires popped out and the tooth, it just dumped because it had memory to where it was before. Let me go back again. So here's where we were. It had dumped. We worked on uprighting it. We got it a little bit better. Then we said, hey, let's use some brackets to work on this. So we start using the brackets. We've got some C-chain to pull it tight. We've got the wire in the slot. And then boom, wire comes out. He bit down on something, popped the wire out, and now the tooth, because it's not kept in the tray, I remember how we said we're trimming the tray, all of a sudden now, crap, this tooth dumps. But it's not the end of the world. All we do is we just put it back in again. And we're working our way up from a light stainless or light night-high wire, like probably like a 16, 14, 16 into an 18. And then we'll go into a square wire. So that's what we do. We go ahead and we put on our square wire, and that now this is not going to pop out at this point. Now we have a nice square wire in here. Again, it was super easy stuff. We're not doing anything too complicated. The one thing you're going to notice though, oh, and then the wire popped out again and it started spinning the tooth slightly. Go back one. But what you're going to notice is that even with us wearing the aligners in the anterior and trying to lock these teeth all in, there is a space that opens up, because as these teeth are all pulling back and uprighting that tooth, there's a reciprocal force that's happening. And because the tray didn't lock in that well to the anterior teeth, then they did pull back slightly. But again, guys, if you right now had this case, right, where there's a bit of rotation, there's a bit of a distal out, and you had a little space there, and that was the patient's chief complaint and they wanted aligners, would you feel comfortable saying like, yeah, I can go ahead and close the space between the canine and the premolar and like rotate a second molar a bit? Easy, right? This is how braces work. You don't necessarily get it all sorted out right away. And that's why aligners are the same thing. You don't always have to worry about not having everything completely done on your first batch. Sometimes it takes time, and sometimes not that it's mistakes. I mean, yes, it is mistakes, but you need to see how things respond and how the body behaves. So at this point now, we go ahead and we use aligners again. So we just take off the brackets. That's it. It's pretty easy stuff. So we take off the brackets. Here's the ClinCheck. Right, we need to close the space between the canine and first premolar, and we need to rotate this lower second molar. I wanted to see how the optimized attachments were holding up to this, so we use optimized attachments here. Just to derotate. Unfortunately, the optimized attachment did not fully rotate the tooth, and there's a teeny bit of space there, no big deal. So we put on a conventional attachment, and we finish that rotation with a conventional attachment. We also put in then, because there was a bit of space, we put in some fake IPR. So that fake IPR is just for us to force the contacts tighter together. Okay, so here's what it looks like on the plan after we use the optimized attachment. Still a little space, not quite rotated enough. Put on our conventional attachment, just get the job done as we derotate that tooth. And this is our final position. So this is after he's been stable in retention. You can see nice contact between the teeth. That tooth's in full occlusion. And let me show you the pan. Here's his initial pan. Here's his pan after that tooth dumps and the roots don't move. And then here's his pan once we have uprighted that root. Now, I'll be honest with you guys, this is not the most efficient plan in the world. There was a number of things I would do completely differently now in terms of how I would deal with that terminal tooth, because we realized that we're trying to move the root too fast. We could have done this with aligners. We could have been successful, but we had a fatal flaw. Once we realized that, yeah, we're going to go ahead and use some brackets and wires, we needed to track and pay more attention to the fact that if the wire pops out in the back, you see him 6 weeks later and it popped out. Well, this is why brackets in some ways suck, because if a wire comes out, the movement that will happen will be a movement that you don't even want. If you lose an attachment on a tooth with aligners, the movement just won't happen, but it will probably hold the tooth where it's currently at. But in that case, when he had his wire pop out, well, then the tooth dumped. Then we had to put the wire back in, and it would have had to upright the tooth and swing the root. So for 6 weeks or 8 weeks, because he didn't realize that wire's out of place, then the tooth's moving. And like you saw how it rotated that terminal tooth as well, we did get the tip, right? The root swung mesially, but then we still had to put aligners back on to finish the rotation. So again, I cover a case or two cases like this in the attachments biomechanics course, showing how we would go ahead and just use aligners for this. And I kind of alluded to a few of those things, like leaving space, working on the root movement and doing it really slowly first, and absolute, utter, complete compliance. But then the second component is again, get the root fully over before you finish moving the crown upright. So that's how we would have done that if it was just using aligners. I know a lot of you right now are clearly select doctors who are currently on this call, but many of you might not be. So my vision for what we're trying to provide doctors is 5 different things. I realize that I can just go ahead and talk about cases and you'll learn from it whatever you learn. But there's a certain aspect that you need more than that, right? And so the first thing you do need, though, is knowledge. You need education. So being part of Clearly Select means that you get access to every clearly aligned course in existence and everything that we've done in terms of our previous recorded content. So like for live lectures that you see in these previews, in these breaks. So if you have that knowledge and you have the education, right, there's over 170 hours and you don't need to do it all, but you have different tracks and pathways that you can follow of whether you want to do really complicated things or if you're a brand new provider and you just want to do basics. But we provide that support with the education and we continually put out new content like this. The second aspect is you need to have confidence. You need to know that somebody's in your corner who's got your back and will support you with ClinCheck design. So we have this in two different ways. We have this through different chat communities that you can be a part of, but you also have it through our ClinCheck design services that any member who's part of Clearly Select will get access to 10 ClinCheck case reviews done by our team with these thorough overviews like you're seeing right now of full breakdowns of these cases. And so being able to take cases that are slightly outside your comfort zone and helping you work on those so that you become more confident with them, but keeping you in the guardrails so you don't crash and burn is so extremely important. So the vision alone is that any doctor in Clearly Select should be doing ideally 10 cases that otherwise would have been a little bit outside your comfort zone that now you can treat. If you normally treat $6,000 per case and the lab isn't 2,000, but imagine your lab was 2,000, it's actually less than that by quite a bit with Clearly Select. But if your lab was less than that, it would be less, or you'd make more money. But let's just say you made $4,000 on 10 cases. The idea is there's no reason that you shouldn't be making $40,000 after lab by being a member of Clearly Select, because we'll support you and give you ClinCheck designs and keep you in the guardrails for you to take on cases that otherwise would have been outside your comfort zone. So the confidence side, right? So number one, knowledge. Number two, confidence. Number three is community. You need to have other people who are going through this journey at the same time that you can communicate with and you can bounce cases off each other and get support from them. And so Clearly Select is not just me. We have our faculty and advisory board. And so we're really working on creating that collaborative community to support doctors extensively, not just in orthodontics, but in other areas. One of the cool things is that we have experts in so many different areas in our group, because the goal of Clearly Select is that this is not just your basic education that anybody can join. We're actually pretty strict. Only half the people who apply to join Clearly Select actually get accepted. So the vision is that this is the Rolex of education. We want people who are committed and who really want to improve. So that's the community aspect. The third one is the logistics, the business, and the profitability. We are able to leverage some of the best discounts in the entire industry. If this is something you're interested in knowing more about, we can go ahead and get into the specifics. But on average, our doctors save $30,000 on their lab costs. Again, $30,000 compared to whatever your tier discount would currently be. We also get discounts from other dental companies like dental monitoring. And so with the different discounts and benefits, financial benefits alone, that's substantially worth it. But in addition to that, right, we're going and giving you business strategies through the different courses and through the different lectures that we do, where we teach you about profitability and marketing and how to organize and set up your office to handle scale, right? We do whatever it is, 400 cases per year in our clinic, and I only work 5 days a month. So we're going to help you with the logistics, the profitability, and the business aspect. And then the final point, which I think is to me the most important of all, is accountability. We're going to hold you accountable. We want you to tell us your goals. If you don't meet them, it's not that we're going to kick you out of the group, but I want you to set targets and actions. And again, this is why I think my patients do really well with Invisalign is I'm giving them direction. I'm coaching them. I'm their personal trainer. So we will give you feedback. We will give you goals. We will help provide different tracks of education for you to be successful, because you need someone in your corner who's going to help push you. And that's something that I really enjoy. So that encompasses what Clearly Select is, but there's so much more than that. We're working right now on a Wikipedia that essentially has videos to answer every single question. you have IPR, you are putting on attachments, you are doing TADs, you're doing impacted canines, you're doing an impacted lower premolar in 30 seconds, right? We're going to have Wikipedia articles that are going to go through and explain all of this, and they're going to be cross-linked. So you can go ahead and be in one and you can start looking at something else. And you can also use our AI chatbot to actually ask questions to get it to give you answers and then focus you in on the right areas. So there's so much coming with Clearly Select. And I'm excited for all the doctors who are already part of our groups. We currently have over 300 practices that are involved with Clearly Select. And this is something that I plan to do for a really long time. I've still got 32 years left currently until I plan to retire. So if you want to be part of this journey with us, whether it's for 5 years or for 30 years, we'll have the information in the description, the website where you can apply to become a candidate and be considered to join Clearly Select if this is something that's interesting to you. Again, you don't have needed to ever do a single case of Invisalign. All we ask is that you're committed to improving and that you have a goal towards excellence. Those are the main things.